Dr. Robert Wood again. Today we're going to talk about the lower extremity examination. The lower extremity examination, we're going to be concentrating mainly on the hip, knee, ankle, and foot. And I generally do start this by having you ambulate. Again, we want to check the gait pattern and have you walk back and forth. And we watch the heel strike, the push off, and see if there's any evidence of any limping for whatever reason it might be. And then I'm going to have you, again, we've already checked before, we can raise up and down your tiptoes and on your heels, okay? And we're checking that motion. We checked the range of motion of the spine previously. I'm going to have you sit up here now, and I'm going to have you actually lie back, and we're going to check the hip motion. Hip motion, we want to palpate the bony prominences first of all. We can feel the anterior superior iliac spine here. We can palpate also the greater trochanter. Bony prominences here, where sometimes they'll get signs of a bursitis in this area can occur. The hip joint itself is actually located in the groin. People come in and say they have hip pain. You have to ask them, what do they mean by that? Because many times people say, my hip hurts, and they mean their buttock. And that's more common. We'll see that with sciatic nerve irritation. Classic hip arthritis is going to be directly in the groin area itself. We check first active range of motion. I'm going to have you, can you pull your knee up to your chest on this side? And we check, when we do this, we want to make sure the lumbar spine stays flat. They're not cheating by raising their pelvis. Now come back out straight. Now the other side. So flexion there and then extension. Okay. I want to check that myself now. And I'll again take them through a range of motion, flexion, extension. While I do this, I also want to check internal and external rotation. So we want to do it first of all by checking internal rotation, where I'm actually rotating the hip inward. Does that cause any discomfort? Okay. And external rotation the same way. And then we can abduct and adduct, and I'll usually abduct the hip and adduct the hip this way. Again, palpating again the greater trochanter area. You can also check the abduction and adduction in the straight position. Adduction and abduction. And if there's a question, I'll have them actually do it simultaneously. Bring your both legs up and bend the knees. And I'm going to have you stretch your legs apart. Okay, good. And we can check one side or the other to see if they rotate internally and then externally equally. I want to check the musculature here. Can you raise your leg up holding it straight? Okay. And on this side. Okay. So that'll check our hip exam. Briefly check the range of motion of the hips. The knee itself, I'm going to have you sit up here now to check the knees. And stop this way a little bit. And I'm going to sit myself to get a better view of this. The knees, not quite as complicated as the shoulder, but probably second in nature to how complicated it is. And there's basically 7 structures we want to consider in the knee examination. The first of which is the extensor mechanism, which makes the quadriceps into the patella attached to the tibial tubercle. So we'll take a look at that. The other anatomical structures we want to look at are the menisci, which are the little curved discs that occur between the femur and the tibia, and I tell people makes the round bone fit better on the flat bone, but gives them some stability as well. And that's located along the joint line, which we're going to talk about in a minute. We then have the ligaments about the knee, because it's not as stable a joint, so it needs something to hold it in place. And we have the medial and the lateral collateral ligament, and that keeps it from going side to side. And then to keep it from going forward and backward, we have the anterior and posterior cruciate ligaments. So we're going to talk about these 7 structures. First of all, I want to see the extensor mechanism. I want to have you straighten it all the way out and back again. I usually want to put my hand on the patella and take them through a range of motion, and as I can feel that as I do it, to see if it's moving smoothly. Very often you'll feel what's called crepitance, which is a kind of a grinding or sandpaper sensation under the kneecap as you make that maneuver, to feel that in there. And you can also get a sensation of warmth about the joint. With them out straight, I'm going to let you bend just about, kind of let it relax. Hard to relax on command, but try to relax the muscle. And I want to look at the kneecap to see how it tracks up and down. It runs through what's called a femoral groove. And I can put my finger extensor mechanism, we can see the musculature coming down, the attachment to the patella, and then the patellar tendon then attaches from here down to the tibial tubercle, which is the prominence in this area. And you want to palpate along that area to make sure there's no discomfort consistent with the patellar tendonitis. I'm going to try to bring you out straight just a minute here and kind of let this relax. And I'll be able to feel the kneecap as I move it back and forth. With it relaxed, there should be some mobility to that patella. And I want to make sure that if it's going to dislocate or sublux, partially dislocate, it tends to go to the outside. And we'll sometimes try to test that by pushing on the inside to see how far it goes. And if they've had problems with that, they'll sometimes stop you at a certain point called an apprehension sign, consistent with the subluxable patella. And when that happens, we need to work on some muscular strengthening here and sometimes surgical realignment of the patella. We can also sometimes see if there's any fluid within the knee in this position. And if there's fluid, you can kind of feel what we call it kind of ballots up and down, or kind of feels kind of like balloon, like there's fluid in there, and there's a way to demonstrate that fluid, which we'll get into later on if you're further interested in joint examinations. Now, the remainder of the examination, that's looking at the extensor mechanism. I'm going to bend it down now. And palpation of the bony prominences. The is here, and the patellar tendon is between the end of the patella, this proposed patella, and the tubercle. If you put your thumb or finger on the patellar tendon and go just laterally and medially to it, you'll feel kind of an empty space here. And that empty space is really the joint line the femur and the tibia, and that's where the meniscus lives. So you can palpate along that joint line to see if it causes any discomfort. Symptoms and signs of a meniscal tear are going to be that there may be a portion of that meniscus that may be torn, but actually locked in the knee. And if that's the case, they lack full extension. They may come out and be locked and not be able to come all the way out straight. So, and you can't bring them out straight because there's a piece of meniscus caught between, and they'll often be tender along that area. There are some tests you can do to try to trap that meniscus, one of which is a McMurray's test, where you kind of twist. You're trying to trap the meniscus between the femur and the tibia. So you kind of grab a hold of the ankle and you bend it up and twist it in so you can kind of trap that. And at the same time, I'm pushing inwards here and outwards here to try to compress that femur and tibia together and lock that meniscus. And as I do that, I bring him into extension. And if he has pain in that area, or a click or a pop, that could indicate a medial meniscal tear. I do the opposite, trying to trap it on this side, where I kind of maneuvered around to try to trap those two joints, push in on the femur, out on the tibia as I bring into extension. And that will sometimes trap it with a lateral McMurray's test indicating a lateral meniscal tear. Has no tenderness along this area. He has full motion. So it's a fairly normal examination of the meniscus. Now, the medial and lateral collateral ligaments. Fairly straightforward. The medial collateral ligament is here, the lateral here, and I'm going to stress from side to side. And I do that by taking my hand and pushing inward on the femur as I push outward on the tibia, and that's going to stress the medial collateral ligament, and you can kind of feel it here. Likewise, the opposite is with the knee slightly bent. If you're out straight, the knee will lock itself. You want to bend it about 30 degrees when you do this, both of these tests. And you want to do the opposite, kind of pull out on the femur as you pull in on the tibia, and that'll stress the lateral collateral ligament. Another maneuver to do that yourself, if you prefer, is just simply have the foot under your arm, and you can put your hand on both sides, bend it about 30 degrees, and then stress it, pushing on the outside to stress the medial collateral ligament, and then push it inside to stress here, and I can palpate that to feel it. And that basically is the medial lateral collateral ligament. If there is a tear, you're going to find that you can compare one side to the other, and there'll be pain along this area, and it may open up slightly like a book, and you'll feel it kind of give at that area, indicating a possible tear. More commonly, the medial collateral ligament as opposed to lateral collateral ligament. Now, the cruciate ligaments are within the interior of the knee, and they make a cross or an X in the joint. The anterior cruciate ligament keeps it from going forward, and the posterior from going backward. So to test those ligaments, there's a couple different tests we can use. If your hand and arm is big enough, you can actually get a hold of the femur and the tibia and just kind of pull it forward, backward, forward. This is called a Lockman's test. I myself like to use what's called a drawer's test, where I actually, let me have you slide back a little bit. We can do it two different ways. We can have you bend your knee up a little bit, and I'm gonna actually put it here. And what I'll do is actually sit on the foot to kind of stabilize it. I'll put my fingers on the front, just adjacent to the tibial tubercle here, on the front of the tibia, and I'll give it a pull, called a drawer's test, and with experience, you can actually, and in comparing one side to the other, you can actually see if there's a tear of the anterior cruciate ligament, it may actually pull forward, and you'll see it kind of separate from under your thumbs from the femur. Likewise, the posterior, when you push backwards, in the same situation, you'll feel it give and go back underneath the femur somewhat. And that's the test that we could use. The other way to do it is, depending on, slide on out here. I sometimes also like to do it just by putting it on the chair that, or stool that I'm sitting on, bend it about 70 degrees, same situation. I have my fingers on, or thumbs on the tibia and the femur, so I can palpate that, and I can feel any give to that. And there is a little bit of give in everybody coming forward and then going posteriorly the same way. And you, again, you want to compare one side to the other, so you get to see if there's a, if they have a match set and that's the way they're built, or whether there's an injury to one side or the other. Because everyone's different in how much laxity they have in some of these areas. So that's the exam of the knee. We've examined the extensor mechanism, medial and lateral meniscus, medial and lateral collateral ligaments, and the anterior and posterior cruciate ligament. Okay, now, as we get down to the next joint, the ankle basically flexes and extends. So we're going to check the motion up and down. On this side, same. Okay, and then the bony prominences we're going to palpate are the medial malleolus, the lateral malleolus, and the calcaneus here. And the talus joint is in this area. Now, we're going to check a couple things in this area to see. The medial ligament is very strong and doesn't usually get injured very often. It's likely to break before this actually gets torn. Ankle sprains normally occur on the outside of the ankle, and there's three basic ligaments that occur here. The anterior talofibular ligament is the one that's most commonly torn in this area. We have the calcaneofibular ligament here as well. To test these, I like to hold the ankle like this, and actually if you bring it in plantar flexion and invert it, that stresses the anterior talofibular ligament. In an ankle sprain, you're going to see a lot of swelling here, and that's going to be uncomfortable in the plantar flex position. If you dorsiflex it and stretch it internally or invert the ankle, it's more stable, and that indicates that the main ligament about this area is torn. The most commonly one is torn is here. If you have what's called a high ankle sprain, you actually tear the ligaments on this side, as well as some of the interosseous membrane that goes up and down between the femur and tibia in this area, and that's a little longer to heal, and you hear that sometimes in athletic injuries. Medial collateral ligament, usually not torn in this area, but you would have tenderness here. Posteriorly, you're going to palpate the Achilles tendon. The gastroc muscle comes down and attaches into the heel, responsible for plantar flexion. If you were to have a tear of this, you would actually do a test where you, and we can do this briefly in a moment, where we squeeze the calf, and it should plantar flex the foot when he's in a kneeling position when he's prone. The other thing that can happen is in the ankle is you can get, like you can in the knee, a drawer's test anterior and posteriorly. So we'll sometimes grasp the tibia, get a hold of the calcaneus here, and try to slide it back and forth to see if there's any instability in the ankle that may occur. You can palpate the tendons that come around the ankle, the posterior tibial tendon, also the posterior tibial pulse in this area, and the perineal tendons on the outside. There's two of these that come down and attach into this. And you can see the prominence here of the tendons that I'm bringing out on profile here. The perineal tendons that come down and attach into this area, one to the base here and one to here. The posterior tibial tendon actually comes down on the just behind the malleolus and attaches into this area, and it's actually quite responsible for maintaining part of the arch. When people have a tear of this as they get older, or they get attenuation as it degenerates, they'll actually get a collapse of the arch sometimes when they're walking. You'll have them stand up. When we talk about people with flat feet, and you want to check the arch when we're getting down to the foot area. You can see you've got a nice arch in the sitting position. And sometimes people will have this, even though they have a flat foot, and it's called a flexible flat foot. I'm going to have you stand up now. Just step up and down here. And you can see he maintains his arch quite nicely. Both sides. Okay, you can sit down now. But sometimes what will happen is they'll have an arch reconstitutes when they sit, but when they stand, the foot hyperpronates or rotates over and flattens the arch. And that's what we're looking at for flat feet. For the foot itself, you have the mid-tarsal joints in this area. If I grasp the calcaneus and the front of the foot and kind of twist back and forth, that stretches the mid-foot area to see if that causes any discomfort from pain here. As we palpate out along the metatarsal areas themselves, we can palpate for any kind of stress fractures along the metatarsals. A common area we'll see between the third and fourth toes. We can sometimes see a neuroma that occurs called a Morton's or plantar's neuroma that can occur. There'll be tendon in this area. We're looking at the status of the nails to see if things move up and down. Can you bend and straighten your toes? Okay, and then we want to look at the plantar aspect of the foot, where they'll get sometimes a heel spur occurring, which is attachment of the plantar fascia into the heel. It's in this area. And we're also looking for any kind of calluses that can develop up along the metatarsal heads.